Thank you very much, dear colleagues, moderators. It's a pleasure to be here. I agree it's an important Congress, and I'm happy to have been invited. Just a few words, actually, on women and atrial fibrillation and the risk of stroke. As we heard, several older studies, which have been confirmed by recent trial data, show this increased risk for stroke in women with atrial fibrillation, significantly higher risk. The mechanisms, however, are really still not very well understood, because we heard that the profile of a woman with atrial fibrillation is different from a man. We heard from the previous speaker, and I selected here two papers that indicate that women with atrial fibrillation are older, and they have more hypertension compared to men with atrial fibrillation. Men, on the other hand, more often have diabetes, heart failure, and ischemic heart disease associated with atrial fibrillation. So in my mind, it's not entirely clear to what extent these comorbidities account for the higher risk of thromboembolism, and on the other hand, to what extent and how can we investigate a potential prothrombotic risk of women compared to men? I think this is an area of investigation. As we heard, in CHA2DS2-VASc, SC stands for sex category, which attributes 1 point in the thromboembolic risk score. On the other hand, female sex category component of the score is most predictive in the presence of multiple additional risk factors. And we use the CHA2DS2-VASc score actually to help us identify the threshold of whether to anticoagulate or not. So if being female adds thromboembolic risk only in the presence of additional risk factors, in practical terms, considering sex is not going to really matter. Indeed, female sex alone, as stated here, or in the presence of only one additional risk factor, does not really, it's not there that we see the increased thromboembolic risk of women with atrial fibrillation. And therefore, at least from a practical point of view, there are certain guidelines, for instance, the 2018 Australian-New Zealand guideline that actually proposed to remove sex category, at least for our practical use, and use a sexless CHA2DS2-VASc abbreviated to CHA2DS2-VASc. Actually, I support this. I have, in my own mind, thought of this for several years. And I think it's a matter that we should discuss further. A few words on DOACs and how they may relate to women with atrial fibrillation. Now, in deciding on which DOAC to use or how to appropriately adjust the doses of the DOAC, renal function probably is the most important player. So we know that dabigatran should not be used for clearance between 15 and 30. We know that rivaroxaban and edoxaban should be reduced, as shown here, when clearance is between 30 and 50 milliliters per minute. We know that apixaban should be halved when clearance is very low. This is often an element that is not well acknowledged, partly because patients tend to be fewer in this range. But if we have a patient on apixaban with 15 to 30, then we should, with this only criterion, reduce apixaban. But then there are other items here, which include body weight, 60 kilograms or below. Now, I see many women here, most or maybe none have atrial fibrillation, but many will have a body weight of 60 kilograms or below. Moreover, The Cockcroft-Gault formula, which is indicated to estimate creatinine clearance to decide whether we should adjust or avoid certain DOACs, includes not only body weight, so the lower the body weight, the lower the creatinine clearance. You see it's on the denominator. And then if we are dealing with female patients, we reduce the calculation by 15%. So let's not decide on whether renal function is good only on creatinine, especially in the elderly, thin, little old lady. We definitely want to estimate creatinine clearance with the consideration of weight and the appropriate dosing. This is probably why overdosing of DOACs is probably more common in women, the body weight and the appropriate creatinine clearance estimation not being optimal. And in case we have bleeding complications, fortunately, we do have 2 reversal agents for the direct thrombin inhibitor, idarucizumab, which is approved and on the market, and of the factor Xa inhibitors, in particular rivaroxaban and apixaban, which is under approval in Europe and approved in America. In general, a few words on DOACs in pregnancy. All DOACs labels advise against the use of DOACs in pregnant women. Why? DOACs are small molecules that cross the placenta. They have not been tested in pregnancy, and animal studies indicate, indeed, potential reproductive toxicity. The International Society on Thrombosis and Hemostasis indicate the following recommendations: counseling for women of childbearing potential that may commence DOACs, encouragement of contraception, switching to alternative anticoagulation preconceptually, discontinuing DOACs if pregnancy occurs unintentionally on DOAC. However, inadvertent exposure to DOAC is not regarded as a medical grounds for termination of pregnancy. Now, let's have a look at the abundant phase 3 trial data on DOACs and atrial fibrillation. We know in general that the 4 trials, major trials listed here, RELY, ROCKET, Aristotle, ENGAGE, for the full dose NOAC showed significant reduction of stroke systemic embolism with the DOAC compared to warfarin without a price to pay in terms of major bleed. Indeed, there was a very favorable trend, so an effective treatment, which is also has a safer profile, especially for intracranial hemorrhage. We know, indeed, that intracranial hemorrhage is reduced by approximately 50% by the use of a DOAC compared to warfarin. We know that mortality is reduced on meta-analysis by 10%, all-cause mortality with the DOAC compared to warfarin. So let's look at the single DOAC trial data. In RELY, dabigatran at the 2 doses compared to warfarin reduced stroke for the higher dose, reduced major bleed for the lower dose of dabigatran, favorable trend in mortality, reduced intracranial hemorrhage. In women, consistent results for efficacy and major bleeding, whether you were a male or a female atrial fibrillation patient, for the higher dose of dabigatran, and also for the lower dose of dabigatran compared to warfarin. So similar efficacy safety results by sex. I liked the distinction that the previous speaker made on sex as biological and gender as being a social condition. So I tried to apply this terminology in this presentation. ROCKET, we know that rivaroxaban compared to warfarin in deep green showed favorable trends in stroke systemic embolism on treatment analysis, reduction of intracranial hemorrhage and fatal bleeds, favorable trend for reduction of all-cause mortality. In terms of sex differences, we see that the efficacy outcomes were not significantly different for men and women. There was, and this is the only analysis that showed actually a potentiated safety profile with rivaroxaban in the women compared to the men. Aristotle, we know that apixaban compared to warfarin in deep purple showed significant reductions in all the outcomes. About 10% reduction in all-cause mortality, 20% reduction in stroke, 30% reduction in major bleeds and halving of intracranial hemorrhage. If we look at efficacy and safety outcomes by gender, again, no significant difference by gender in terms of prevention of stroke, systemic embolism, or in this case, prevention of major bleeds. Finally, ENGAGE is shown here, overall trial results. The 2 doses of edoxaban, only 60 milligrams is approved worldwide. Significant reduction in stroke systemic embolism, reduction in major bleeding for both doses, favorable trend in death, and also marked reduction in intracranial hemorrhage. Again, efficacy and safety by gender, no significant P4 interaction, so we can apply the overall trial data to men and women and use these DOACs as tested in the trials. If we actually do the meta-analysis of all the 4 trials we just showed, as done by Ruff in The Lancet, where the dabigatran was only tested at 150 milligrams twice daily because it's the only dose approved in the United States, we see the message confirmed. Efficacy outcomes similar in men and women for the DOAC compared to warfarin, superior efficacy, and very favorable reduction in major bleeds. Now, there was one meta-analysis that actually included all the DOAC doses. It included also the dabigatran 110 milligrams twice daily, but also edoxaban 30 milligrams once daily, which is not approved. So I believe this is a limitation of this meta-analysis. It showed that there was a trend towards greater efficacy of DOAC in men versus women compared to warfarin, and greater safety of DOACs in women versus men compared to warfarin. Just a few final slides on the real-world data to try to get a handle on what is happening worldwide. This is a huge Swedish registry, fairly recent, men and women with atrial fibrillation, and an interesting picture emerges in this and in the following 2 slides. If we focus on the higher CHA2DS2-VASc score, here we have the women, here we have the men, and here we have anticoagulation, VKA, and DOAC. They're actually similar in men and women for a higher CHA2DS2-VASc score. So major differences instead occur in that confused area where CHA2DS2-VASc is taken into account, the 1 point for gender, et cetera, and which in my mind may account for these disparities, where we see more men being treated compared to women. The GLORIA registry is another large registry of 15,000 patients, and again we see the same picture. Here it's arranged differently. We have the higher CHA2DS2-VASc on the right comparing women to men, and again you see that the bars are really quite similar, where the red and the blue are vitamin K antagonist and NOAC. So with the CHA2DS2-VASc of 2 or more, men and women are treated quite similarly. I think this is these are fairly recent data. On the other hand, lower CHA2DS2-VASc show the disparities that we mentioned before, with more men being treated than women. If we take a score that is sexless, like the HAS-BLED, then we don't see the disparities. So again, I believe this CHA2DS2-VASc decision to use gender is confusing rather than helpful, and probably clinicians are doing the right thing, actually. Finally, this is not a very large registry, but it was the most very recent one that again gives this information that at higher CHA2DS2-VASc 2 or above, women and men are treated similarly in terms of anticoagulation compared to aspirin or treatment, with disparities at the low CHA2DS2-VASc. So my take-home messages are, in summary, that women with atrial fibrillation are older and more often hypertensive than men, A sexless CHADS-VAS score is recommended by Australian New Zealand atrial fibrillation guidelines. The safety and efficacy of DOACs compared to warfarin do not differ significantly in my mind by sex. And recent registries, fortunately, do not show gender gaps in atrial fibrillation-related oral anticoagulation for CHADS-VAS scores of 2 or above. Thank you very much for your attention.